Can you change the voice?
No, it's not like Siri.
Not a lot of people.
The clock on my phone works.
Yeah.
Very bad. She didn't hear it. Yeah.
Something ever changed. Calling the meeting to order. This is the Indian River County Hospital District Chairman's meeting on February the 18th at 9 a.m. It took me a lot to remember. So glad everybody's here. This is our first time at 9 a.m. We'll see how it goes after a couple of these and see if, if we said we would start at 9, not meaning that we have to go to noon. But when we're done with discussion and business, then we will adjourn. So starting off the meeting, we've got a community survey results. You'll recall that we engaged Clearview Research and Steve Vancor to do some additional work for us. So Frank, will you?
Sure. We have Clearview Research and Stephen Vancor on the phone. And if everyone recalls, year and a half ago or so, we started a process and we did our first study last January where we wanted to get community input in a representative sample of the folks in our county. And we wanted to ask their opinions on access and affordability to healthcare. And we would take that data and that information, look at the trends, and then help it inform our strategic planning and our decision-making in the future. Everything being based on, evidence and factual information. And so we've got some really good feedback this year. And that's what Mr. Vancor is going to talk about. Stephen, if you could, please.
Thank you very much. Appreciate it. Before I put on the screen share, I have to tell you, this is really exciting for me as a pollster because a lot of times you do a poll, you give a public opinion poll, and then people go about their merry way, and that's fine. A lot of times we continue to work. This is one of those examples that I would love to show a case as a case study, and I'll demonstrate why. We did the pre-poll. It guided your team, Frank and your team, to certain strategic actions. And frankly, as you'll see, and here's the cool part about this. It's a blind treatment. We did not know what actions you had taken in the interim. We've had some minor contacts back and forth with the hospital district, but we did not know some of the things you had done in the interim, which is perfect, right? It's like a blind study. And when we were going over the preliminary results with Frank and Caitlin, it was astonishing for him to say, oh yeah, we focused on this, we focused on that. And so you do the A test, you do the treatment, and then you do the B test to see if it works. So let me put on the screen share and I'll show you what I'm talking about. So for basics, I'm going to enlarge this so you can see it. So starting with the basic, and is that a little too big, right? Can you guys see that okay?
Yeah.
Okay, good. So just for those of you who don't know, we use what's called in the polling industry, the gold standard, which is live outbound callers to our target audiences, which is, general residencies. And we balanced it to look as much as possible like the general population so that we have a representative sample. So by doing the live outbound callers, we get a random sample. And by balancing it across 5 different variables, we get a representative sample. And so, for example, we know that approximately 52% of the residents are female. So 52% of our poll is females. And likewise, we balanced it by age, race/ethnicity, and region to make sure the entire county was represented. We got a 600 sample, which is a solid sample, and it allows us also to look underneath those numbers. Now, overall findings, key findings, whoops, sorry. It does that sometimes. I apologize. Let me just put this back. Okay, so the overall findings are, and I want you to look at this chart for a second. You'll see we compared last year's to this year's, and you don't see dramatic changes from satisfaction with overall access to healthcare services, overall affordability, and then availability, meaning they can have access to physicians when and where they need them, or medical services when and where they need it. You had a very minor, but had we seen dramatic changes between the beginning and the end, it would have stunned us, right? So we see throughout these gentle changes, almost all of them blowing in the right direction. So a modest increase in overall satisfaction, a +2 on the positive side, and a -5 on the negative side, which translates to a 7% shift, which is not bad. On affordability, about a net 4. But look at availability. It's a pretty dramatic jump of 19 points. And so our takeaway is overall changes plus net 7 improvement, pretty good, about as much as you can do given all of the variables that are out there in the ecosystem, and how much you can actually effectuate change in 1 year. Affordability positive, but appointment availability was stunningly large, and we'll get to the punchline on that in a little bit. So, also we from our first poll, Frank and his team and you guys wanted to dive in a little deeper. So, because we found that women under 50 were unsatisfied outliers. They were less at 31% difference, which is significant. So we broke out, was it the fact that they're more likely to have children? Is it availability for their children? Is it availability for themselves? And so we broke those out. And what we learned is availability for their children is fine. But availability for themselves, women under 50 remain an outlier group in your organization, for getting that. And if you think about this for a second, that probably makes sense. These are likely lower income for a variety of sociological reasons. They also likely to have more medical appointments with gynecological and wellness care for women. So they have more of it than, not less, where men under 50 probably don't go to the doctor as often unless they're smashing a thumb working in the garage or something. But also the fact that they're primary caregivers and they're also having to care for their children, putting themselves off in second. I don't know what it is. If we ever wanted to know, we could maybe do a focus group of them and find out. But the bottom line is that's one of those groups that remains problematic for us. But it's not because they don't have availability for their kids, which was whoever, Frank, I don't recall who it was who said we need to break that out this year, and we did, and so we were able to hone in on that. Okay, moving forward. Yeah.
Steven, before you go on, we've got a question from a trustee.
Sure.
Hi, it's Karen Deagle. In that group, did you take into consideration parents, taking care of parents? I think that would be more of a concern than having children.
That's a really good question. We did not.
Thank you.
That's a good note we should take if we want to look at it there. But I know that's a relatively small population, relative to the overall population, but certainly something we could look at. But we did not. We did not tease that one out. Good question, because they got to care upwards and down for the kids too. All right. So then moving on. Overall key findings, then we drilled down a little bit to see where there might be areas, but you'll notice for specialist care, that went up in the right direction. Urgent care went backwards a little bit, okay, -4, and primary care went up +4. So urgent care is the only variable, and you'll see I do a summary of these variables where we went backwards a little bit. And 4 is about margin of error, but what I look at is if they're all within the margin of error, but they're all pointing in the same direction, that's a good indicator, right? So you have, but if you look at for specialist care, you have +5 on the positive side, -11 on the negative side. That's a +16. That's pretty strong. Urgent care -4, primary care +4 overall.
And really quick, Steve, if I can interject.
Sure,
Hi, I'm
please.
Karen. I work closely with Steve. And when we're looking at that urgent care access, what we see is it's not a move from yes, I can get into no, I can't, but rather, yes, I can get into I'm not sure if I can. And we do anecdotally guess that could have more to do with people who were going to urgent care less if they were seeing their primary care doctor more. So that's important to consider.
Yeah, that if it's the old meme, right? It's like if you get primary care, you're less likely to get urgent care. And if you put those two variables together, that's what it seems that, because as Karen pointed, they didn't go from no, it's gotten worse. They went from I don't know. And so maybe they don't know because they've been getting more primary care visits. But again, that's logical speculation, but speculation nonetheless. And then on healthcare utilization, you'll see regular checkups went up a smidge. Prescription affordability went downward, and that's important. Appointment cost barrier went up slightly, and a distance barrier, how far they have to drive, went down slightly. Okay, and I'm gonna summarize those because that could get confusing as to which is which. Now, appointment cost barrier, another thing we teased out was for children. Parents with children report significantly higher barriers due to cost. At 28% agree overall. Karen, explain the change from year over. I'm a little confused on that. Is that in the right direction or the wrong direction?
Right.
Or we're not comparing A to B. Okay, never mind. Yeah, this is the parents with children. Okay.
Yeah, this is a subgroup, so we could again look at whether or not it's a issue of is children's healthcare more expensive, or is that the factor being children versus other factors that coexist with people who are more likely to have children. And this kind of reflects what we saw in the last analysis we did of that subgroup, which is they're slightly higher, but they're aligned enough that it's a third variable more likely.
And then on dental care, this is really interesting. Quality of care went up slightly, +3 on the positive, -5, so it's an 8-point improvement. But look at choice of providers, a 17-point increase on that. And then availability, also a 17-point increase. Little punchline here, when we were doing this review, Frank started laughing. I'm like, what's going on? He goes, yeah, we opened up a new dental clinic. I'm like, well, guess what? They're aware of it and it shows. And quite, you're not looking at single digit improvements here. You're looking at double digits improvement. In 1 year, we've done a number of these healthcare surveys throughout the state over the past decades. That kind of movement is very large, not just statistically significant, but relatively large as well. So you had a 17-point net movement, positive net movement on choice and availability, which is fantastic. And it shows that we didn't know you had done that, and then it shows up in the data. For parents with children are also aligned with the base at about 77%, but slightly lower favorability rates for their children's care availability, but really within the margin of error, kind of slight decrease for their kids. This is cool stuff too. So we have routine screenings such as colonoscopies, mammograms, or pap smears. A little confusing to read this, but the bottom line is we're looking at overall net increases in routine screenings, a decrease in emergency room services, increase in primary care visits, behavioral and visits to the dentist office, all net positive movement. So that's really good. So here's what I wanted to show you. I think this is kind of cool. If you look at, let me just make sure they're all on the page together. Hang on, let me just drop this back to, is that too small? Hang on.
No, it is too small.
That's sorry. How about that? A little better? Here we go. If you look at the ones that were positive, appointment availability, choice, and we put them in order, choice of dental providers, dental appointment availability, specialist access, right? Dental quality of care. All the ones that are positive are the things that are in your control. Now, appointment cost barrier with constant, we're still under pressure nationally, globally on economics, right? We're in a tough economic climate right now, and we have been for the past several years. prescription affordability, that's also something, unless you're giving it away, you really can't change. Distance barrier, well, if somebody decides to live far away from medical facilities, that's still there, but a net 4 increase, and that's a negative for us. And urgent care access has dropped 4 points. Okay, but those move to unsure. The point being, the things that are in your control are all trending in the right direction from various levels. Listen, let's face it, regular checkups +2 is probably, statistical noise. Affordability net +4, also statistical noise, and that's probably not in your control, except for maybe co-pays and stuff like that. But those variables taken together tell a very interesting story, that the steps you have taken since last year seem to be having a positive effect. Now, the challenge for you would be to keep that trend going, because there is a ceiling, right? There's a statistical ceiling of 100%, but there's a realistic ceiling of movement. So while this is fantastic, it would be unbelievable if we can somehow keep the trend coming. You keep going. Your challenge, I think, going into next year will be to keep these high numbers high, especially given, if the Obamacare subsidies fade and people, it's going to be a big affordability issue for a lot of families. Who knows what's going to happen with Medicaid? There's things outside of your control that you cannot impact. But it seems to me that the things you've done showed in the poll. And again, we did not sit down and say, what is it you did while doing the poll? We did largely the same poll to see if there were movement on those variables. So conclusions, I don't need to read all these to you, but I think the point being, overall, we're seeing modest but meaningful improvements across the board, whether it's availability, access, quality, provider quality, anything else that I missed. The system access appears to be improving, but cost sensitivity, especially medication costs, continue to constrain perceived affordability, which can undermine long-term satisfaction if not addressed either within or without our control. And I don't know that. And in terms of children, households with children, which we wanted to especially focus on this year, it's as high or higher than the other groups. But they're more likely to report cost-related barriers, which makes sense. Younger families with children are going to be more economically stressed, just statistically. And the dental and behavioral health access for children remains an area of comparatively higher uncertainty with larger unsures. We also did a Medicaid subgroup, and they generally track the basic population, which is phenomenal, right? Because that's usually the group that has to wait at clinics and longer lines, et cetera, but they seem generally happy along with the overall group. Conclusion, although not isolated as a standalone subgroup in every comparison, respondents without insurance consistently show lower affordability scores. Again, that makes perfect sense, and a higher likelihood of delay in care. Again, if economics is a barrier, I'm less likely to go to the doctor if I just merely, cut my finger, something I could repair myself. And women under 50 continue to stand out as a statistically significant subgroup that needs continued special attention. So our recommendations from that, we probably need to work a little bit more on cost awareness moving forward, although I would be remiss if I didn't stop and say, again, good job, guys. This whole team on this call, you saw the need, you implemented strategic changes, and they're showing in the public opinion direction, even against national trade winds, which often affect a lot of these polls. Household with children remain a high need group, maintain focus on Medicaid and uninsured populations, and sustain the preventative care momentum, because I don't need to tell you guys, the more preventative care they get, obviously the healthier they are, the more cost savings and the fewer emergency room visits and other things like that. So with that, I'm happy I can either end the share or let me end the share, but open it up if anybody has any questions, comments, observations.
And do we have that report?
We do.
Okay,
We do.
I'd like to see.
Okay.
Yesterday.
Oh, sorry, my bad. Apologies. Questions from trustees?
Very good report.
I saw, this is Michael Kent, I
Hi.
saw a recommendation relative to trying to give a greater focus in the surveys to Medicaid and uninsured next year. It's a population that's significant here, and I don't think is as broadly represented as maybe it should be, and I think that probably is born in that recommendation. The other one that I was just trying to decide.
Michael, what we could do next time, we could either like do an oversample of lower income families, which we can pull a special data set from to give it a more stable response set, right? Because if it's, let's say it's 18% of the population, that's going to be 18. If it's 20% of the population, that's going to be what, 600 times 2, 120 people. So we could do an oversample of lower income folks so we can hone in on them a little closer if you think that's a wise way to go.
Yeah, Dr. Mackett, and correct me if I'm wrong, but I thought I heard you speculate or say that population of women under the age of 50 may be of lower income, so that might help target that population as well.
Yeah, that could be a spurious variable because if you know, listen, if I'm lower income, you know, my groceries are going to feel more out of sync, right? My healthcare access is going to, and especially if I have children, I have to spend money, right? As a father of 3 boys, I know you have to spend a lot more money on food and other things. And so when it comes to healthcare costs, it's going to be more of an issue than somebody who makes a lot of money and is on Medicare. So, yeah.
And we know in terms of there's about 1,200 babies that arrive each year here in Indian River County. And the Medicaid population there is quite significant and it bounces between 50 and 60%. So again, that is that lower income, younger probably, but we hear that in one regard, and I'm just cognizant of the fact maybe they're not underrepresented as part of the total population here, but I don't think it's a bad thing to what you said. You can give it focus in whatever your terminology was, under something. Go for it.
Oversample.
Yeah,
Oversample.
we would oversample them so that we
Yeah.
can have a robust universe of them. Because at 120 is still a pretty decent universe. It's just got a very wide margin of error. But if you wanted, if you said, "Hey, Steve, we want to focus on that group explicitly to make sure we have a good, valid sample, so we know what some of their issues are in a deeper level." Because then once we do that, then we can look at men, women, and different age groups within that cohort. Because right now you can't, because if you break that group in half, for example, if you look at just women, just low income, you're going to be talking 20, 30 people, maybe most. And then that's not going to be a valid enough sample, a large enough sample to draw conclusions from.
Right.
Karen?
Madam Chair and Frank, so what are we doing with this information and what are the next moves with this project?
Well, the first thing we wanted to do was make sure that the trustees, you know, heard the latest information. Caitlin and I just heard, you know, a week and a half ago. And then I want to take some of the recommendations from Stephen and Karen and discuss adding those to our future survey for next year. And then, you know, how we use that information and how you internalize it and use that as you review the funding applications. That's where I think it should be applied. You know, we apply this information towards this year's funding cycle, which has just gotten underway with our LOIs. So
I was also, do we usually put this on the website?
we do.
We do,
Yeah, we
okay,
post it.
great. And how do we make sure that people know that's on the website? Is that, I don't know how to do that.
What did we do last year, Kim?
Well, I have it on the same page of the dashboard. It is
Okay.
all of the survey, this will be on there,
Okay.
and then I had created, it's like its own separate dashboard with last year, so I'll upload all of the new stuff from this year as well, but it's on that same,
Okay.
like data page. Website.
Any other questions, comments? Stephen, thank you very much.
Well,
Thanks.
great job, guys. Really. Your challenges, you just won a bowl game. Now you got to come back. And the first question we ask right at the end of the game is, how are you going to do again next year? So good for you. Congratulations. Really. Thank you for having us. I appreciate it. Any other questions?
Thank you. No.
All right, Frank, we'll reconnect.
Sounds good. Thanks so much.
All right. You're welcome.
Okay. Chip Jacoby,
Thanks.
you're up next.
Okay.
You
You know what, why don't we, it's Shen, can you slide a chair in down with you and Kate? I know you can. Big group tables.
Morning, all. Okay, so I'm here to go over our agreed upon procedures portion of the work that we do for you, and we issued the report a few weeks ago, and so we're here to go through it. I'll highlight some things. Effectively, the report is a series of mini reports. They're identical letters for each organization that we did the special testing for, which was in essence testing that there was compliance with your indigent care policies. Essentially looking at the income and residence policies and requirements that you have to support those services. So what I might point you to is page 1 of the document, because it gives an overview of all on one page, and so we'll kind of focus on that. We focused on the agencies you asked us to test, which were mental health, New Horizons, Treasure Coast Community Health, Visiting Nurse Association, and Whole Family Health Center. And you can see the total funding by agencies, some of which is not based on the fee-for-service portions. They were some of the portions of the funding were direct funding. So where it says NA, those pieces were not subject to the testing. And it shows the total patients in the population and the samples that we selected for each of those populations, and then the exceptions that we found. And then going through and testing, it's basically a yes/no question and answer. Is the information there showing compliance, or is it not? And so you can see for mental health, we found no exceptions. Prior year, we found 1. The year before that, we had 0. New Horizons jumped up this year with 9 exceptions compared to 1 in the prior year and 0 in the year before that. But when you dive into the detail and look at the 9, they're all the same issue. So we'll talk about that in a second. Treasure Coast Community Health, in looking at the medical and behavioral health area, we found no exceptions. We had 1 each in the last 2 prior years. And in the dental, we found 1 exception, as we did in the prior year, but 0 in the year before that. Visiting Nurse Association, we found 2 exceptions, 1 and 3 in prior years respectively, 0 in the hospice care program. And then for Whole Family Health, we found 0, whereas in the 2 prior years, we had 2 each. Karen?
Except as I noticed, the sample testing size is pretty much the same throughout all of them, except your number of patients is quite significantly different.
Yes, so a little bit based on statistical audit and theory, we're looking at a 95% confidence level with a 5% error rate. And the statistical calculations for a population drives at 58. We increase it to 65, so the sample is tolerant of finding an exception without blowing the conclusion that you're in compliance with the 95 and above. So it's kind of.
Okay, I trust you then. Wow, okay.
So we try to base it on that. It's not a dollar value sampling. If you did a dollar value sampling where you said, okay, here are the dollar exceptions and we want to project that to the population, it would be a much larger sample to get there. This is just an attribute yes/no question, and so the statistical theory drives you there. For smaller populations, we talk through with staff and we say, okay, if we have 63, let's take half. We can't do 65, but let's get some coverage. And so we chose to do 32. And I'm looking at VNA.
Yeah.
14, we tested all.
So for an accounting perspective, irrespective of your population, if you dip below a sample of 58, your data and your view becomes less reliable.
Yes, what it drives you to in the calculations, instead of 95 and 5, maybe you're 90% confident at the 5% level. So the 95 and 5 is kind of a standard goal in all auditing. You wouldn't want to pay us to do 100% or get a really high level of confidence at a low error rate, because you start to get to a cost benefit decision.
It's not a Jacoby Handley determination of 65. This is an industry
Yes,
accepted standard.
yes,
Well,
yes,
it's a statistical
Exactly.
power.
Yeah.
You're powering the question by getting it statistically.
yeah. If any of you went through statistical classes.
Not well.
Not well, right, which is why I asked that question.
Yeah, and it goes back to those formulas that you saw the professors write up on the board so quickly.
Yeah, let me just add, this is Frank Geisley, that for the county, so the county population of 170,000, we sample 600, which is within that 95%. You've got the confidence interval, it's the same. So the same statistics apply on 170,000 people, 600 is representative with a 95% confidence interval.
Yeah. Yeah, and so we're really looking for, we look for the compliance, but we're looking for trends too. What are we seeing that might be issues that you can attack and go back and, train or re-educate in terms of some of the data collection? The process over the last several years, 5-10 years, with the introduction of the hospital district numbering program and the data collection and the process that the agencies accumulate the data and submit it for further review at the hospital district level. I continue to believe it's working really well. The exceptions that we see are not significant, but there are things to learn. So 8 years with the HE program. It's been a while. So it's really working nicely. So to have tested 355, we did come up with 12 exceptions, but again, when you go back, and look at New Horizons, it's effectively 1 because it was consistent across those 9. So that really brings your compliance, it showcases the compliance that you have for the systems. The next page takes those exceptions and adds or creates a dollar value to those, so that you can see in essence what the impact is across that testing. We came up with a total of $17,226 of exceptions, 14,000 comparatively in the prior year, but 26,000 in the year before that. That's not on the type page. One of the things we do in addition to just going through and making a selection of samples, through the power of Excel, we write various different if-then types of formulations, and we take the whole population and subject those tests. In that process, we came up with 3 of the agencies, actually 2 agencies, that had submitted some duplicate invoices for patients. Same day, same procedure, same patient. And so we identified those as well. This year it came into a total of $5,531, compared to just $1,000 in the prior year. So when we get these exceptions, by the way, we pass them back. They have that information.
Okay, this Alan Jones. When you calculate these numbers, is that based on the 12 exceptions you found? Or do you project that out over?
No projections.
So it'd be a multiple of this would be, if that, assuming that the numbers are right.
Yes.
So I'd have to do the math on that one,
but again, in order to do that dollar value projection, you'd have to get a statistically sound process, you'd have to test a lot more. Many more
different questions.
To get a bigger, to get a more accurate error rate.
Correct. At a dollar value level.
Yeah, it's just powered to find an exception. It's not powered to get
To an attribute, yes.
Yeah.
Did they prove residence by
Right,
proper
right.
documentation or did they not? I would be careful to take that for the statistical.
Yeah, well,
reasons.
thanks for educating me on that.
Yeah.
I see what you're talking about.
So,
Yeah, but because I also feel, anecdotally, judgmentally, that there is a compliance to these. It's just that we found that the documentation was missing here or there. But the preponderance of the evidence in these, I think if you go further, I think you'd find that those exceptions would go away.
and it's a yes or no, did they obtain the two points of identification, not whether or not they're actual residents? In other words, the numbers you have are whether or not the proper documentation for residency was submitted, not whether or not they were residents.
Yeah.
So I could have they could have taken 2 copies of my driver's license and it would have come out in your report as non-compliant, but if that driver's license shows Vero Beach, I'm still a resident.
Yes.
Okay.
Yeah. Yeah, we didn't find any situations where somebody provided a driver's license and it said Palm Beach County. Yeah. So, if I can go into a few of the pages, I'll point out, back to page 6, and this is for mental health. This is a situation where you require 2 different types of documentations and you have a listing of what qualifies for those types of things. In the mental health case, this was the only agency that in the sample, we found 2 patients that to prove residency with 2 documents, they had 2 different payroll sets. You know, for, let's just say, January 15th and January 31st. Technically, they're considering that to be compliant with your policy. My recommendation, particularly since it was the only agency, and once I saw that, we went back through all the different samples that we looked at, that was the only agency that had that. It feels like it's not in the spirit of what you're trying to get to, because 2 payroll stubs out of the same payroll system sound like the same document to me.
Yeah.
So I would suggest you go back and look at that and maybe talk through that with mental health and change that so that they have 2 different types of documents.
In our policies, does it specifically state that?
No, it's,
So maybe that's something that we have to look at, is how we, because probably they're compliant at this point according to our policy.
yeah. So that's a recommendation that I would have. Going back to page 9, this is in New Horizons. So of the 49 patients files tested, the policy exception, and they were all the same for the 9. The second proof of residency documentation was the same as the applicant's photo identification. And there again, you're requiring that not be the case. So again, didn't see any situation where they weren't residents. But again, just cleaning up that issue, I think will take care of that exception with New Horizons. You know, when I go to page 12 for CCCH, the one exception we found of everything that we tested was simply that for some reason that applicant's file that we had selected had not been properly saved, and so the data was gone, and so we treated it as an exception because it wasn't supported. That doesn't mean that it wasn't supported through the process and, you know, prior to losing the information. That was really all that I wanted to highlight for you. I'm happy to answer any questions, but again, I continue to see that it's a clean up process and well documented, and that process is working for you.
Questions?
A question maybe for Caitlin, just in terms of, these are obviously the 5 agencies that are most heavily utilized by those indigent patrons that are aligned with us. Are there 1 or 2 other agencies that numbers are are growing and should be added to the list, or is this capturing the?
I mean, I think we've talked about what agencies should be using the portal. I think a lot of it comes down to ones that are doing like medical billing, because that I think is where it's more important to be sure that patients don't have insurance and we aren't being billed for a visit that could have been billed to their insurance. So a lot of it is tied to the agencies that are also billing insurance for the same visit. So it depends on the agency if they're gonna be billing the same visit, potentially us versus insurance. I think that's where we would more look to add them to the portal. So.
So staff is comfortable with these five is what it comes down to.
Well, one of the things that I think the five for now makes the most sense, as we evolve, perhaps that'll
Yeah.
grow. But for now, I think it makes sense.
Any other questions from trustees? Yeah, I'm just gonna, once I got through the trustees, Dr. Perlman.
Yes, I have a question. We only had page one. We didn't have the rest of the report, so it might not make a difference, but I'm curious as to why you lump medical and behavioral together in terms of your audit. I mean, the billing practices are very, very different for medical event versus behavioral. E&M codes, therapy codes. Why do you lump the whole thing together and not break it out?
We can look at doing that. We take the spreadsheets that are provided as part of the invoicing process and they come through. We do have them separate. So we can actually subject each of those, separate them out and increase the sample similarly for those two different pieces if that's what the district would like us to do.
Thank you.
But we'll talk about that for the upcoming process.
So thank you.
Thanks for asking that question.
This is Michael again, just a statement about the fact that, we talk so often about, seems lately, about the performance review that we've been through where we're being audited, and we obviously do audits annually. I've said this before, but this particular document is only another level of, scrutiny, that we impose on ourselves, to show that we're working hard to make sure that, the citizenry is not going to say we're wasting their money. These dollars, this is fairly de minimis when you look at the grand scheme of things. And I think that's important. It's just another document that we have in our arsenal when we have to show the state or others, that we're, safeguarding their dollars.
We've been doing this type of project and study for like 20 years, maybe plus. And it goes back into the days when the primary focus was the hospital. And not the exception differences in the dollar values of those were dramatically higher. And I think there was a real effort over those earlier years to work through and the differences swung both ways. Sometimes you owed some money back to the hospital when we found some things where they had been rejected. So it's interesting, but it really has become more fine-tuned.
Karen?
The dollar amount that is stated in there, what happens in this case when there are they paying back?
Right, that's right. Same question.
Is that what happens? So the dollar amount that you show in here, is that what the organization pays us back?
No,
Or
In recent years, I think it's been at your discretion, as you say, and I don't know that that's occurred. I think on the duplicates that we find that those are
It's different.
addressed. But in terms of some of these, I think it's more of looking for lessons learned as opposed to.
I just remember the hospital would pay us back
Well-
when it was 25 years ago. It would take us,
The
so
worst-
that's a whole
The
different.
worst impact
Yeah.
in 1 year in those early years
Yeah, I
was
know.
about $500,000.
Yeah.
So
Yeah.
absolutely, we're going back and resettling up on those, but
Okay,
and again, I think because of the discretion, you're looking at some of these, the totality and preponderance of evidence suggests that they really met the criteria. It's just that technically one or two things that come down with So, I think that's how you've looked at it.
Yeah.
Makes sense. Kip, thank you very much.
Thank you very much.
Thank you very much for.
Are you done with us now for the year?
Yes,
Okay.
well, we've already started the process. Our new
State isn't so, yeah.
So it's good to hear that we're looking at the same five, and if you want to change that at all, just ask me. But we're already working with staff on the next sample.
Thank you
Thank you
very much.
Have a great day.
Thank you.
Thanks,
Yeah.
Okay, update on VCOM lease addendums.
All right, Dana is on Zoom as well. I believe she wasn't gonna be able to attend, but she had a meeting with so she's gonna chime in as well. As you all may recall, we did an extension to finalize a lease amendment or addendum with VCOM for the Human Services Building. And that is through currently March 10th of this year, so it's coming up pretty
Coming up,
quick
yeah.
here on February 18th. It seems like we just did that, but it's been a quick series of time. And so I do believe Dr. Cannon
He's on,
is
he's
on
on
as
second.
well. To be able to answer any questions that you all may have about what deliverables ultimately we want to put in this document. So we thought it was appropriate to have him join us today and have discussion on that before we were to finalize it. And it may be that after our discussion, we may need a motion to further extend the time for the amendment to either the March meeting or after the March meeting. It's entirely possible on our end that we can get this pulled together for you to approve at your March meetings, but if you're not ready to do that, we don't need to rush the process, is our opinion. So that's where we stand from a legal standpoint. I'm happy to answer any questions, or you can open up the floor,
Let
Matt.
me just say, this is Frank Isley. We wanted to have Dr. Cannon on as well, because even though we've had lots of calls and we've talked quite a bit about next steps and responding to VCOM's existing proposal with the updated timelines. And there's a lot of consensus about how the trustees feel about the response. But I wanted to create an opportunity just so we could publicly bring on VCOM and the trustees could ask any questions that you may have, whether it's related to the agreement or just related to the progression of the school and the third and fourth year students or legislation or anything related to that. So Dr. Cannon has joined us for that.
It's Paul Westcott, excuse me, Paul Westcott. You met, or Dana and Frank, have you met with all the trustees and received input as to what might go into an amendment? Are we gonna see that today?
We can't share discussions that are outside of sunshine, so
I'm talking about the product of that, other words,
yeah, we're
Okay.
going to have discussion as a group to hear from each of you, and then we'll be able to put a product together at this point.
then my inclination is March is gonna be premature
I
and
agree.
very optimistic.
I really agree with that.
So, you know, we can
You may wanna see the product at the market.
exactly discuss the various components and then look at a final document in April or May. So what we're looking at is the extension of the opportunity to continue the discussions with a final product at
Yes.
sometime in the future, probably is what we probably want to do today.
Yes, we'd be looking
Okay.
for a motion like that towards the end of this discussion today, if that suits the board.
And Paul, this was the last step of that, of putting together a response from Jennifer's team, is to just bring Dr. Cannon on and see if there's any questions that people have, any clarifications that are needed. He's willing and able to answer them.
And there really are a lot of components to this. It's not just a simple lease and let's get them in the building as a tenant, as you all know. So we really wanted to give this the discussion that it warrants.
Indeed.
And I'll have to say that I would probably like to see the document and have Dr. Cannon on once I see the document, because that's when I'll have more questions.
For sure.
And I think to chime in, this is Dana McNally. I just wanted to make sure in discussions with Frank that any questions that the trustees had, specifically when it came to what is VCOM's vision, things like that, that we collectively independently wouldn't have that firsthand knowledge, that you all are able to ask those questions, because that's what will go into that document that you will see. So there may be 2 rounds of questions. I just think from a fact-finding perspective, this is an important one to have before we get that final document.
Alan?
This is Alan Jones, just wanted to to ask a speculative question, Dr. Cannon. One thing that occurs to me is that the proposal that you all submitted is really based on permitting and also getting approval at various levels to go forward. How would you feel about starting to put some money forward? Maybe like rent, maybe 25, 30,000 a month, whatever we thought was fair. And then you could draw down on that when you begin to have to do the work. We would make that available to you. But in the event you never do get to do the work, we get some rent for this.
I understand what you're saying, and thank you for the opportunity to be here. I thank you for the opportunity to work with Dana and Frank and everyone. And so what we're looking at right now, and I've shared all this, or if you've heard all this before, then please stop me. But I have a document here that's in tentative, it's in draft, and what we intend to do to answer, I will answer your question, sir, is the first floor would be a simulation room. We're looking at standardized patient rooms. This is all in the purpose of what is our why? Our why is to bring more physicians to the Indian River area. And how do we do that? We do it, one, with medical education, but two, with residency programs. And so we spoke with the higher administration of Cleveland Clinic, not just for Indian River, but statewide Cleveland Clinic in Florida. And their quote was, we're committed to GME, graduate medical education, residency programs in Indian River. We are active and ongoing in our discussions with the main campus in Cleveland, Ohio, to make sure this gets done. And so the way to do that ultimately is when you have a fourth-year medical student graduate, go into residency, most of the time they will practice, over 60% of the time they'll stay and practice in the general area where they did residency. So that's why we're doing this. We have a belief that if we have the residency programs there, they will do that. So part of the agreement, which we appreciate, is to have no rent in order to provide what we expect after talking with Proctor Construction, about $2 to $2.5 million worth of renovations that are needed for the building right now. And so that's just the first estimate of what they see by their walkthrough and by what needs to be done. And so if we were going to put 2.5 million in, then we were hoping that we wouldn't have the rent. So to your point, I believe what I'm hearing is in the interim, pay money for rent. The counter to that is, in full transparency, is the bill. Is we are not, if we just have no access to be in based on Senate Bill 7016 that has been passed in March of 24, and we do have consultation with people trying to get VCOM's name on that. But if that is unsuccessful to be considered a medical school in Florida, or even to have space in Florida, considering that we have nearly 500 graduates fully licensed and board certified in Florida, we have 255 Floridians in our school presently, we feel we should be included on that bill. But if we're not, then we're investing in something that we can never be in based on Florida law. And so that's our big holdup right here, is to try to get that. As soon as that can get done, we're full speed ahead. But looking at it, that we work on the backs of tuition dollars from our students to pay money into a building that we have potentially do not be in is not the most fiduciary responsible thing.
Well, I've got Dr. Cannon, this is going to sound critical. When we started the relationship, my expectation was that you all would be knocking on the doors in Tallahassee much sooner than you have. And as a result, it's the process is drawn out. If I was aware of and had seen you all in Tallahassee knocking on the doors, I would be less inclined to agree with Alan Jones, but we've got an asset. Just from our perspective is looking after the taxpayers' interest. We've got a significant asset that is drawing down on our finances that could generate rent, should be generating rent. And I appreciate that there are influences out there that are beyond your control, but to the extent you all have control and influence, I haven't seen what I would like to have seen.
Sure, and I respect that, and I appreciate that comment. I mean, there's truth to that. We were given just the full truth. We were given extreme confidence that the bill was going to be passed and through channels, and we were given, hey, it's going to be done. Hold tight, and it wasn't, and that's bad consultation, bad advice. Someone that didn't follow through on their promise that we felt would deliver, but that is the truth on that. But so what, we were not knocking on everyone's door because we had someone in South Carolina that had relations with people legislatively in Florida that said it would go through. That didn't happen. So now we're seeking consultation in Tallahassee. Had a meeting with people last week trying to help to get that done. But I do see your point, sir.
Dr. Mackett?
Yeah, Dr. Mackett, just a clarification for Frank and then 2 questions for Dr. Cannon. At this time, VCOM is still paying for utilities.
Correct. They're paying all expenses. They're paying the carrying costs. Correct.
Right. So it's not that the hospital district is not getting some financial benefit out of this relationship. And then Dr. Cannon, Matt, Chuck, good to see you again. So I was a little confused by your statement about not putting money into an asset that you potentially may not be able to use. Does that mean you are not gonna spend the $2.5 million for the development until you get approval in the Senate bill?
That is not great. Thank you for that, Chuck. That is not definitively the case. No. So what we're trying to do, we have 20 students currently in Vero Beach 3rd years and 20 4th years, so 40 students total. And so we would like to have a facility to train them more effectively, to have the simulation centers, to have the classrooms. Right now, there really is very little, if any, space inside the main building. And talking with the hospital, they have no intention of making anything bigger for us. And so we would like to have this space to do that. That being said, we really would like to have, looking at it again, strictly financially, we really would need 30, if not 35 or 40 students down there for each year, 3rd year and 4th year. So we started talking about Tradition Hospital, Martin North, Martin South, simply because we want to be able to have a place where they can go and congregate for classroom activity, for didactics, for simulation, for the transition to residency. And looking at it, well, if you have 20 students versus 40, it makes a lot more financial sense from the school to invest that much money. And so that's something we're working with on the Cleveland Clinic end, is to say, hey, can we start ramping up the number of students that are here? If you can't house them all in Indian River, 20 and 20, can we go to 25 and 25? And that's what we're looking at for this upcoming academic year in July of 26 to increase to 25 and then to 30, just to justify that spending $2 million, 2.5 or more. That's just for the renovation. Then you put a sim center in, that's going to be anywhere from $500,000 to $1 million there. And then putting in more equipment and classrooms and things like that. So to answer your question, Dr. Mackett, is no, that doesn't mean that we're not willing to invest. It just means we're trying to find all the pieces, but it's not just one piece. It's, well, can I get Cleveland to start increasing the number of students and helping to make room for more students to then further justify that expense?
Yeah, thank you. Yeah, thank you, Dr. Cannon, for clarifying that. And then my second question, Matt, you referenced meeting last week with folks to further the inclusion in the Senate bill. I just wondered if you had an update for the board on your discussions with Mr. Ken Pruitt.
Sure. He said to me that it was a little late in just where they're going right now, but he said it's greater than 50% chance. He said he would put it at above 50%. So I said, well, how high above that? He said, well, I don't really know yet until I look into what that, who I can talk to, who I need to meet with, what bills. He has to put it on to another health bill in order to get it through. And so So I didn't get any more information other than above 50%.
Booney?
Yes, assuming this all goes through with up in Tallahassee, what do you see time-wise to bring the staff, the support people you would need to actually have a medical school up and running and the tradition? I'm kind of familiar with that, having had residency in other training programs up in Mayo Clinic, so that takes time. What's your game plan for that?
So we believe, truthfully, we believe that certain schools aren't always doing it the most responsible way. A lot of times you'll see that there's new schools that have come into Florida, just 2 of them just in the last 2 years, and they put in their first and second year. We have 4 campuses with first and second year. That's an easy move to transition our same curriculum into the first and second year and have students in the classroom. Third and fourth year in medical school is when you have the real clinical experience. And so to bring in an average of 160 students, 162, and then you have your first and second year, well, where are they going to rotate? Where are they going to get the good quality experience that you need to make competent physicians? And if we do that on the front end, where we establish the third and fourth year rotations beginning, then the first 2 years are easy. So to answer your question is right now to just have 20 and 20, that's not enough. And so then we said, well, if you go up to 40 and 40, well, then you're making some headway, but you still have to have more of an outreach and more opportunities. And so depending on if we can know that we're in the state of Florida and that we're satisfied by all legal means, then it allows you the opportunity to grow into these relationships. So you might say, well, why don't you do that beforehand? Well, do you have... You're working with Cleveland Clinic. That's our main focus. Can you reach out to other partners? HCA, is that going to be fine? Is that not fine? Are there other hospital systems that allow you to do that while you're maintaining your relationship with the primary ship of Cleveland Clinic? And then you develop relationships with each of these hospitals to have the clinical sites, but then you're told, oh, you can't be there. Well, now you've gone through. And so to answer your question, is I believe the bill is essential, which allows us to go forward. But that being said, I think it will move very rapidly, in a steady, consistent pace for developing the third and fourth year rotations, which then subsequently could allow for a first and second.
Yeah, I just wonder if you can do it in parallel with having an optimistic attitude that all would go well in Tallahassee, that you'd be making those steps, and particularly with Cleveland Clinics and their academic side, you need the clinical professors and so on to really make this happen. So just a question. I understand your problem.
Very valid question. And we've talked with Mandy Siegel, I believe her name is, and she is over academics for all of Cleveland and Florida. And there's 5 hospitals. I believe a 6th hospital is going to be built, starting construction. And so we've been talking with her about getting us down even in Weston. That's so Martin North, Martin South, Indian River, Tradition, and Weston. And then eventually the next hospital. And so those are all being discussed right now. And how many can they provide total, then coupled with other hospitals around the area to allow for 160 learners to be in the clinical setting.
Good. That's good information to know that it's spread throughout Cleveland Clinic, Florida, rather than just Indian River. Good for you.
Paul Westcott, Dr. McKinnon, my thinking may be flawed, but when we started the process, the legislature, this may seem snarky, legislature's there once a year, every year. So if not this year, next year, or the year after. And I've been of the mind that, moving forward with the school to the extent we can by law and continue to knock on the door while building and demonstrating a program will add to the pressure. And so, my hope is that we can work together and come up with a game plan that facilitates that process so that even if it's not next year, okay, we can still handle through, I guess, the 4th year and continue to apply pressure in Tallahassee is the way that I've been looking at the situation. So if not this year, next year, or the year after.
Reason, and thank you for that. These are all valid questions. The reason is honestly the way the wording is written. It says give priority and preference to other schools. There's a committee that's been formed to how are they going to uphold this law? How are they going to, what are the standards of it? How is this going to be enforced? And so they don't even have that yet to us. And so if it's going to absolutely be that we cannot be there and it's dead in the water. It's just this school, and I hear your point. There's a valid side to that, but we look at it as also, we run on about 98% of tuition dollars. There is only 2% comes through grants for research and things like that. And so we're the third least expensive private medical school in the country. And when we look at that, we weigh out, we have 255 Floridians. We need to be down there. How many of them want to go back? How many will go back? Coupled with, if we don't have the access and we can't be down there, then are we wasting their money? I heard a gentleman before talking about making good stewards of the money of the people, and it's the same type thing. So I hear your point from your perspective, and that's where your focus is on Indian River. We're looking at it from the whole of just how do you spend the tuition dollars most effectively of the students.
Dr. Mackett?
Yeah, Dr. Cannon, Dr. Mackett again. I discussed this offline with Frank, but I'll bring it up with you. In this community, while only 2% of your funding comes from grants and potentially donors, in this community, there's an opportunity for a much bigger share of that. And I would recommend as you move forward, consider looking at local donors and perhaps even naming opportunities for a simulation and training center for potential primary care physicians. And I would think you would have a lot of interest in this community for moving forward in a partnership with VCOM.
Thank you, Dr. Mackett, for that information. I'm writing it down right now.
Here,
Yes, Michael, I'm sorry.
Michael Kent, this may be an obvious question, but I'm very pleased in the sense of what I've heard before and today that Cleveland is very much on board. And when you speak more inclusively of all of the hospitals, as Ms. Pruitt and whatever team you're pulling together is working the trenches, and again, we're 2/3 of the way through this year's legislature, so it doesn't feel particularly optimistic.
With all the special sessions are gonna have.
That's true. My point is, they've been here a while, and I think they have a pretty quality reputation, particularly maybe based more out of Weston. I hope that beyond making commitments to the residencies, places for your students, they may also have pull in Tallahassee, so that Ken is working with them so that you can leverage anything and everything that might get you there.
Thank you for that comment, sir. Yes, sir. We have spoken with councils and consultants from them as well to ask for their assistance. And they have been willing to.
Any additional questions?
Just one, Alan Jones, Dr. Cannon. I'd be curious in your perspective on why Tallahassee is resistant to you being able to move forward to solve a problem that's clearly statewide.
And that's a great question from our end. And what we've heard is that they have simple laws that say you have to have a medical license number to be considered a medical school. And in order to be a medical school, you need to be in the state of Florida. And so we're saying, well, we can have this building, we will have an address, we will have a location. And it's more of this, what we've been told is this chicken or egg concept is that, well, you need to have this in order to make it happen. And so, okay, so if you're telling us definitively that if we invest the money and we are at this building and it's a lease, is that going to make it a difference versus we own this building? And can you be out at any time versus, okay, then we need to talk to the board about, can we buy it? And then that secures us in the area. And then, so that's just this it's back and forth of like, but when we look at the numbers, and I know you've heard this before, but we're just getting started. And at 500 plus people in 74% in rural or medically underserved areas, 255 Floridians currently enrolled. It just seems like we're doing more than what some potential other schools and those that are especially just getting started are doing. But it's this back and forth of, well, you have to be here. Well, we can be there. Well, but you're not here yet. Okay, so if we're there, do you guarantee us in? Well, we have to feel it's never been just a definitive yes or no answer.
Politics.
Wow,
Well,
that's an embarrassment for the state of Florida,
Mhm.
the way I look at it.
Dr. Mackett?
Yeah, question for Frank and Jennifer. Would extending the lease discussion through the end of April meet our requirements for being able to get the information back and?
I think it would be sufficient time. I don't know. Dr. Candy, can you speak to any VCOM timing, budgetary constraints or anything like that? If we decide to push the decision instead of to the end of March, we work towards the end of April?
No issues whatsoever, Frank.
Is that a motion?
That's the question.
Dr. McCann, I want to, will the legislature look at you differently if you own the physical plant?
That is what we've asked, and we still, great question. And we still did not get a straight answer from that, because what they said was you must be physically in Florida. And we said, we are there. And they said, well, what is the address? And we said that. And they said, okay, is that your building? Well, they know that it's leased. Okay, well, then if we own it, is that it? Well, it's still, you would think to me, just Matt Cannon talking, that would be an easy answer. Yes, if you're there, then you're in. And that it never was an easy answer. And I'm still trying to grapple why that is such a hard answer to answer for us. But Mike, it would definitely behoove us. To answer your question, sir, it would definitely behoove us if we had physical ownership of property, because I think that just takes out any ambiguity or gray area.
Well, do you want to buy it?
Is it for sale right now for current? I mean,
It could be.
Make us an offer. No, it's all seriousness. I think that's something we ought to explore then.
Yeah. Matt, happy to talk offline.
Yeah.
Dr. Cooney?
I was just gonna add to that, it seems to me that's the bottom line. They need to have proof of ownership or stronger, and do they need communication from us related to that in a strong way?
Well, I know that I'm hoping that Mr. Pruitt, who's been fantastic, was fantastic on our kickoff call, is working on getting some of these answers. And by the discussion we had, no doubt he's trying to understand what's behind the slow progress that we've made. But we can talk offline about that, Matt.
Thank you, Frank. And thank you all members of the board. Thank you for the opportunity just to be here and answer questions. I sincerely mean that.
Okay. Do we need a motion to extend?
I move that we extend the discussion of the VCOM lease extension for our May meeting.
I like that.
The
I'll
May
second
chairman's meeting.
May chairman's meeting.
Okay.
So say that one again.
That we extend our discussions for the VCOM lease.
So right now, they don't have a lease with us, is that? what
They do.
They
They have an
do.
active lease.
And the active lease
Either
and
we do an addendum or an amendment, I don't know when the lease term ends, but we had triggers in there for them to do certain things
Right.
that have passed, so we looked at it and said, let's connect with them and find out what we can do in an addendum or amendment that's going to make sense with the current circumstances, so that's what we're trying to work through, an addendum or an amendment.
May 20th.
To make the terms
Right.
reflect what's actually going on
what is happening.
and what makes sense for the parties.
And so you're,
This grace period would be extended until May 20th. That's by my motion.
And is there a number with that, Dr. Cooney? Is there a number with that? I thought it was $1 million or something that they're.
No, that's what we're.
That's what
we're
we're trying to
do.
deliberate on
The
that.
grace period to deal
The
with.
grace period. Okay.
Financial.
Right.
Okay.
Nothing to do with the actual wording in the addendum, just a date to keep us going.
I would second that motion.
I have a second
Oh.
from Alan.
Thank you.
Any further discussion? All in favor?
Aye.
Any opposed? Great. Thank you.
Can I say one thing? Dr. Cannon, I think we would like to leave this meeting with leaving you with the impression we really want to work with you to have this work out.
Absolutely.
So despite all the questions and comments we've had, that's our spirit of where we're trying to go forward. However, you gotta work with us some too.
Thank you, Alan.
Sure. Thank you for that comment, sir. Genuinely, I really want this too. I've seen it happen in our city here where I was born and raised and where I'm sitting right now. And we were in desperate need of primary care physicians. And we have over 50 of our graduates currently practicing in primary care in this area today and in this one city. And so I really want to see that generally come through and come to fruition in Indian River and the surrounding areas, because I know it can happen. And I think it's just it's a big win for all the citizens. And so that's what I just want that as well. So thank you for the statement.
Great. Thanks for your.
Thank you.
Thank you. Michael.
This might be more of an other business. It's a tangential issue here. And I'm not foreshadowing anything outside of, we own that building, there it sits. I don't know that we've had much discussion about what happens if VCOM can't pull this off. You know, we've got a value, we've got some kind of tentative sense of what the building is valued at, but we also know it's quite old and needs a great deal of work. It might be an interesting discussion, and it might be too premature to have it. But I'd kind of like to have a greater sense of, well, what might our options be with that if we can't go forward? And I want VCOM to be here. I think we all collectively want that. But let's not get caught off guard. Let's at least have a little bit of a discussion at some point about what options might be.
Maybe after session.
Agree. Yeah.
This is Frank. Well, I will say that, you know, Paul did bring that up a couple of years ago, and I did look into and track down some options for use cases for that property, where it is, considering, you know, Cleveland has first right of refusal and all that. And I guess there's more to talk about on that, but because of the location of the building, because of the work that needs to be put into it, there weren't a ton of use cases. People weren't necessarily knocking down our door. I can say that we did get some updated lease information. So when we leased the building to the BNA on a monthly basis, it was $22,000 a month. The value we have now in a pretty conservative, you know, estimate I got from TP Kennedy last week, a couple weeks ago, it was in a range of 20 to 24 per square foot. So if we just take 22 as is, this makes it 30,000 a month rent. But again, this is as is. And I can tell you that nobody would probably move into that place and try to run a business out of there as it currently is.
Well, let's plot that somewhere in the future so that we can
Indeed.
have a more in-depth discussion. Thank you.
Thanks, Mike.
Jennifer, you all have what you need?
We do.
Okay,
We'll be bringing some further work back to you for your consideration and further discussion.
great. Thank you.
Thank you.
Okay, we're moving on to 10th Street property and Thrive's proposal or pro forma that we asked them to submit to us. So we have Thrive here. I'm wondering if there are any questions based on the information they provided.
This is Frank. Perhaps I could talk a little bit about the concept, just to remind everyone and tee it up before we get into any questions. So what Thrive proposed was to do a centralized intake with respite housing. And this is for folks suffering from substance use disorders that could access a 24/7 centralized intake. And that would have the associated respite housing for them for stabilization. They're looking for no cost to the district upfront. They're looking for rent abatement for 3 years. And options after that. Options include, do they buy? Does the district offer a mortgage?
there's lots of things that we can entertain. But part of this is the FAR Level 4 certified recovery residents, which would be part of this project. They included the staffing plan, which they would implement. We had, Jenny and I did sit with them and get some clarifying questions as far as how sure are you about these income sources? How many staff do you really need when you open up? Is it going to make sense to fully staff? And they were able to answer all those questions very well. And I know there's been lots of back and forth specific questions between the trustees and the team at Thrive. And we've invited them here today, just if there's any questions specific to program, Carrie can speak to it, finance, David could speak to it, or Kylie could speak to any data questions. But really, they're here just for any clarifying questions that you may have.
Anybody? Not bracket?
Yeah, Dr. Mackett, thank you for the update, to the proposal, the LOI. I read in detail the options after year 3 that you proposed. I'm just trying to get a sense, is there a real commitment to lease to buy? Or is that still just a possible option? Because you made a strong case that it would make more financial sense for you to buy them than to continue to lease it.
So, yes, I mean, it would make more financial sense to buy it than to lease it. We do believe that capital campaign for the purchase of the building is feasible to raise a substantial portion, around $2 million or so to put down, and then more than the balance, which would bring us under what the proposed rent rate would be. And the sustainability of that is very feasible. I mean, and that is something we are committed to do.
Thank you.
Paul?
Yeah, on the project budget form, the public funding opioid, is that the opioid litigation money? And do you have a commitment that that's going to be, or is paid to you? Because if I thought, my recollection is that goes through the county commission. And are they committed that money is going to be directed toward you?
That money comes into the state, or comes to the state and comes to the county. That those funds are committed for at least the next 16 years. The county does have to approve those funding on an annual or 2 to 3 year basis, depending on however they choose to do that. They have that discretion. We have been awarded funding for this current year. We were awarded funding in the initial part of the settlement of it. And there are limitations on where the funding can go. It's not just open for the county to give it to anybody. There are restrictions, and there is a task force, and the Public Safety Committee that reports to the county commission, is the driver of where those funds go. And that committee is committed, it's made up of many members in the community, law enforcement, behavioral health, mental health, hospital, and others are committed to supporting this project.
We worked really closely with the county commissioners to organize our community around those settlement funds. So we did do that needs assessment. We have the task force that is making those recommendations back to public safety, which then the county commissioners approve or not on funding recommendations. But it is based on the strategic priorities that went from the needs assessment, this being the key priority from the needs assessment. So confident that would continue to be supported by the county.
Evidence-based.
Michael, Ken, the first two funder were the questions I had, and the first has been asked about the opioid funds. I just had the sense that Southeast Florida has been backing away from our county in any number of ways. I don't know enough about them. I don't know if there are real dollars that they have access to that might be made available here. And obviously there's, fairly nominal amount that's there. Talk to me again about that entity and what any possibilities are, and is there any leverage that we can bring?
Southeast Florida sits on our task force, which recognizes and values the need for centralized intake. We have a long-standing relationship with Southeast Florida. About how much in our budget current?
1.5.
That, you know, and long-standing commitment, relationship and partnership to.
That's a number that makes more sense.
For addressing the needs in our community, we are really,
They're programmatic.
Yeah.
So the part of the agreement with SEPN is we don't go through annual contracts with them. We get a 3-year contract. We are in year 2 of 3 of that currently. And so as we come into a year from now, we'll go into what is called our budget negotiation process. That negotiation process is our opportunity to go back to them and ask for new services, try to amend rate dollars and stuff like that. We are working with Southeast Florida Behavioral now and looking at having respite care added to our OCAs, our covered services, because that is not something we've had previously. It's not guaranteed to happen mid-cycle, but it is something that as we go into next year. And so the limited amount that we put in is based on funding that we are currently receiving from them, funding that is currently committed that we can draw down out of what the available pot. We have not, in an effort of being conservative, put in the estimate of what that will be, because we don't know what those numbers are yet. And I would just emphasize that this budget on the revenue side is conservative. On the expense side, it is not conservative. Overall, we have presented a very conservative budget that, as we do with our annual budget, we are absolutely confident of being able to deliver the net.
And if I might underscore just on the ability to secure the resources, I mentioned that this project is a strategic priority of the county.
Right.
The Southeast Florida led the triennial needs assessment for our region. Projects similar to this were identified as a need and a priority for funding. And so that gives us some leverage to go back and ask for dollars if we needed that, as it's a priority identified in their triennial needs assessment. And at the federal level, this is now the White House signed an executive order really calling out nationally, we have a fragmented system of care. This is really a solution to that fragmented system of care, not only here, but on the national level. And so there are opportunities at the local, state and federal level to support a project like this based on the data and the needs.
Who are our county representatives or representatives on that board for SEPN?
Wes Salmon.
Wes
Mental Health
serves.
Collaborative.
There's only one, and it's Wes. Wes.
And Wes is part of the task force and very involved in this whole project.
Thank you.
One other note on the revenue, and maybe something that's asked, but the public funding, we've already addressed, have secured SEPN is there. Johns Island Community Service League has committed their funding. We have a grant award letter from them. Johns Island Foundation as well. We have a letter from them of committed funding. Theirs does have a caveat, it is pending this building, but they do have committed funding. So we have already pre-committed funding secured and ready to move forward. So they're not question marks on where this is coming from.
These projects are very excited about the potential for this project.
Did you say though, David, did you say that there's a ticking clock on if certain things don't happen, that there's funding that is going to potentially go away?
The Johns Island Foundation has made the funding contingent on approval of use of the 10th Street property.
And they put a date in
By what time?
May. May was the there was the specific date in May was it?
Paul, did you have something?
Give me a minute or two.
Okay, Alan.
Yeah, Alan Jones, I would like, well, first of all, I want to thank Carrie, in fact, the whole staff for being so responsive, at least for all the questions I've asked, and I think a number of you as well. So thank you for that. Secondly, I'm going to state the obvious, but I think it's worth putting on the table. We've owned this building or this property for going on 15 months. And it's been nothing but expense. We've had 4 proposals of how it might be used. None of them similar to what the original intention was, but nonetheless, in my view, this one from Thrive is the only one that has potential to really help our community. I look at our community as being like any other community, except we have 170,000 people, not 1.5 million or whatever. But we got the same proportionate problems. And we need to solve them. But it's more difficult for us because sometimes it's not as economic, which is where I think the hospital district can step in. So I'm anxious to get moving on this and make a decision. In my mind, we either do Thrive or we sell a building. Thrive is proposed, but a combination of both, which I think has a potential to really help the community. But if it doesn't work out, for whatever reason, all these variables that are there, then I think we can still say, well, we tried and we'll let him sell the building. But, or maybe some other proposal will come forward. But right now, I support the Thrive proposal. And I really appreciate the staff answering all these questions that all of us have asked. And I think it's a way to really help the community. And it's being done in some of our neighboring communities to some degree. So I think, and I'm not a substance abuser yet. It's always time. This thing. I think you'd never say never, but the idea that when you need help, you can only get it 9 to 5, 5 days a week is not the way to solve the problem. This is an opportunity to do 24/7, 7 days a week. And I think we'll try it.
Paul?
I'm leaning toward the sale. I think that rather than a option to buy, it's a commitment to buy. I think that needs to be part of the deal up front, in my view. And I'll be honest with you, if that's where we are, the details are less critical to me. In terms of, because in the back of my mind are questions regarding what is the hard data concerning the number of beds that are being needed for our county. The sooner we don't own it, the better economic opportunities they have because they can go outside of the county. I'm a little concerned, Alan made the comment that this isn't where we started and that's in the back of my mind been on it because we bought a property thinking we were going to go one direction, but because of the zoning limitations, we were kind of forced to go in a different direction. Are we forcing a square peg in a round hole because we own the place? If we don't own the place, who cares? As long as we get a fair price for it. So.
Okay.
What if it was the sale, what option, there's 2 and there's 3. One, we hold the mortgage, the other, they go out and do a capital campaign. I assume that it either is fine with Thrive, is that correct?
Both would involve a capital campaign,
Okay.
we would put the $2 million, and whether that would be the $2 million deposit on the building. And the hospital district continue to hold the note and finance it and earn the interest off of it. Or whether that's $2 million that we pay to XYZ local bank. And they hold the mortgage. I mean, that is the trustee.
And we're not married to just those 2, those,
Right.
if there was another option that was brought to us, we're open to looking at anything else.
Another option would be a balloon payment 3 years out, so that you would either pay it off outright or you'd find private financing. Be risky for you all potentially, but that option's out there too.
Under 2, option B does talk about that balloon payment.
No, go ahead.
Harry, we're talking about some things that would need board approval, would need probably board discussion. I'm curious, what has the board's discussion been up until this point about this project and any conversation that they've had about the future with these models here?
Yeah, and so monthly board meetings just talking about what funds we have secured, what the plan is in securing funds. The board is really making a shift towards securing more philanthropic dollars for the organization as a whole. And then really identifying, we've had some conversations with donors about this project in particular. And so,
Our action planning that took place a year ago, it was more directives. To address the housing need that we had and centralized intake. And so this came out of an idea this came out of the needs assessment, but then did the needs assessment. And then seeing what it is that we can respond to. There were a number of items that the board put on our action agenda for this coming year, and we had to select which targeted areas we were going after to work on. Centralized intake and housing was one of the directives that the board gave us. Purchasing, one of the ideas was purchasing 2 additional houses. This is a much better situation, I think, for the community as a whole in the continuum of care. So this started as a direction of the board, and they are supporting.
The board is behind this project, seeing it to fruition. And recognizing though, that we've got, kind of what the plan A, B, or C, what, kind of we're hinging on a decision being made here and then bringing that back to the board of like, okay, now what would next steps be?
Okay, and so if we get to something, then you'll need to take it back to your board for approval and because of the entering into contract.
We do tomorrow.
If we need to add that to the agenda, just let us know.
Michael?
I think at our last chairman's meeting, I pretty much said what Alan said. I'm supportive. In the back of my mind, you are a very valuable organization. And the programs that you provide are critical. I needed to feel that this wasn't a bridge too far.
Yeah.
That it's a golden opportunity, you see, others saw it too, but I don't want the organization to shortchange the community by stretching.
Yeah.
I don't think this is mission creep at all. I think this is square in your wheelhouse. You are following exactly what the task force has said was one of the lead, if not the primary, focus that should be given. I agree with, I think what Paul said, rather than a lease, I'd really like to have, I think there might be a D option here, which is not a lease option, both, make a commitment, and let's go forward with it, but I think you've satisfied that concern that just noodles around in the back of my brain a little bit. I see that this has clearly been thought through significantly and repeatedly. Hearing about what your board has had to say. And with that, I'm leaning very heavily to supporting this.
Dr. Brackett?
Yeah, Dr. Mackett. Just refresh my memory again. So proceeding with centralized intake and the respite care does not require a zoning change. Correct, or no zoning. Thank you.
Karen?
And to go off of that, if they purchase the property, it's their problem.
Right.
It's not our problem. If they go further, take it further, and they need that zoning change, that will not be.
They certainly have to do their own due diligence.
That's correct, exactly. I just want to say that, I was really on the fence. Again, exactly what Michael said, I was concerned that it was a stretch, that they were fitting trying to fit a program to have that property. And I had the opportunity yesterday to meet with Carrie and staff and Congressman Herodopoulos, and Frank was there as well. And I am extremely impressed with Carrie and her team, the passion that they have, and the forward thinking they have about this program and all of their programs, and how to sustain, and that they are not sitting on their laurels expecting the hospital district to be the payer of resource, as we see in the pro forma that they have done. They certainly have done a lot of due diligence and come up with a number of plans that would really work. I am definitely for selling the property to them. I think it needs to be in their hands for them to be able to do what they need to do. Michael, you and the finance team, I think, need to take a look at the two different, what would work best for the hospital district or the taxpayers. I would expect that we would want to hear from our finance committee advisors as to whether we should hold a mortgage or not. I don't know if that's appropriate or not.
Yeah, be honest, it's not an area I have any experience with, but.
Right, exactly.
That makes the most sense.
Nor do I, so,
We'll drill down.
yeah, I'd like to see. At one point, I didn't want to see it in your hands, to be truthfully honest, because I was worried for you. I'm not so much anymore, and so, yeah, I'm supportive of it as long as it's being purchased.
Paul?
We want to have a motion directing the finance committee. I move that we task the finance committee with exploring the options for the sale of the property
To thrive.
to Thrive, and providing recommendations for the best options.
We have a second,
Second.
further discussion? When,
Just
the
make
next
one-
The next meeting just got rescheduled to March 15th.
16th.
They did it again. Yeah.
I just want to make one comment. I'm sensitive to comments that Michael and Karen made about. So as the finance committee considers this, we need to consider not only what's best for the district, but also what's best for Thrive, being able to sustain this effort financially. So anyway, that's my opinion. So for its worth.
okay, so we're in discussion, so committee meets again before our next chairman's meeting? Do you-
It's gonna be the Monday
Yeah.
before.
You think you could have an update?
Well,
For the
Yeah,
chairman's.
we'll
meeting?
get information out to them.
And
I'll
Mark.
talk to Frank.
Yeah.
Um,
We can.
Would there be a special meeting maybe could be called for this, just to deal with that on its
we
own?
just had trouble right now
Okay.
trying to get.
Yeah, so that's
Concern
fine,
form.
just was asking.
Yeah. Okay. Any further discussion? All in favor?
Aye.
Hi.
Any opposed? Hi, very good, yes,
We got public comment.
oh, okay. Public-
Sorry.
I
Sorry.
put it down at the bottom,
Should give a message.
that's all right, that's all right. Is there any public comment after, yes,
Bob Atwater, Eddie River Shores. I don't have a comment about Thrive and work to do. I don't have the expertise. I do have expertise in finance, and the hospital district is not a bank. And in terms of providing a sell a note, I don't think that is appropriate. You're being asked to evaluate the financial performance of a nonprofit going out under some of these scenarios a long time. That would be extremely difficult to do. So I don't think it's the way to go.
thank you. Karen, yes,
Yeah,
Mary Beth.
Mary Beth Cunningham, since we're very weird. Yeah, Carrie and I have done a lot of talking and I've reviewed this and, originally number one in the, for lack of, this community support was a women's sober home. And that was the direction that we were going. And then, yeah, unfortunately, it didn't work out with the zoning and all that kind of thing. But this is a fine, property here. And it's fine for exactly what Carrie is doing. And I guess I'm a little confused about what you just agreed to, because what they're talking about is 3 years of leasing it and then looking at selling it in one way or another that you come up to. So what I didn't hear from you all is, I mean, their board is waiting to find out what's going on, and so are a number of investors. And I'm on the community foundation now. I know there's a number of investors that are also waiting to find out what this board is gonna do. So am I hearing that you're supporting Thrive to lease it for 3 years and then sell it?
No.
And try and
Get
figure
a
out,
recommendation from the finance committee first.
but you're looking at a recommendation on which way to buy, right?
Yes.
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 So are you telling them that they might have to buy it right away?
Yeah.
That could be a possibility as well.
We're waiting for the recommendation, or at least in my view, waiting for the recommendation of what would be best from the finance committee.
That's not necessarily what I heard. I heard that you were looking more to the point of what Mr. Harper spoke to, you know, whether we should hold
Right.
a note on this or not. I mean, that's what I basically heard.
Well, I just urge you to make some decisions.
in our proposal, the 3 years of rent abatement was what our request was, and purchasing it at year 4, at the end of year 3.
And I'm not gonna rush this decision. We kind of rushed the decision and bought a property that's not zoned for what we wanted to use it for. I'm not gonna replicate the mistake by being rushed.
We don't take straw poll votes here. I mean, I think if you can read the room, I think that you're heard some folks that have pretty directly expressed support for letting you move forward. That's not a vote that's been taken, it hasn't been proposed, but I think you've got a good chance based on what I'm feeling, as I read the room. And we don't talk outside of the meetings. So I would hope that we can move that way at the next meeting. March meeting.
Right.
Andrew, question. So the LOI process was given to 4 agencies and it appears that you are moving in the direction of Thrive. Should there be any communication to the other 3 entities to say we are not moving forward with your proposal, or is that premature? Because I would say Frank and I would put something together on behalf of the board. So I would like maybe just direction on that.
Yeah, my interpretation of the meeting where Karen made the motion that we're focused was Thrive probably teed us up to do that anyway, so.
So I'm sure they've been listening.
Yeah.
But
We should.
you should, no,
Yeah.
absolutely, we should. Absolutely.
Okay.
I think it's time. I think it's time.
And I'm gonna follow up on what Mary Beth said, in all fairness to Thrive as well. I think that is one of the, you know, the questions when we come back with our, from the finance committee is, you know, and we want them to be successful, so I can't say right now whether there would be 3 years or of them,
Right.
you know, of the rent abatement, or we want them to move quicker on that. I think that has to be a whole,
Right.
you know, a good discussion.
That's what I heard.
That's what I did too, and I understand the speediness of it. I get that, but
This is a big deal.
it's a big deal.
Yeah.
Would it,
For both
Yeah.
organizations.
would it be appropriate for with us to select somebody to appoint personally, one of the trustees?
Karen has said.
this point.
And I
I
think,
need to talk with Thrive about going forward.
yeah, I think that would be, and I think that they need to be included in these discussions. As much as we want to discuss it with get ideas from the finance committee, we need to have more
Yeah.
communication between the 2 parties now as to how we're gonna make this work and what's possible for you. So I would be more than happy to continue to do that.
Thank you. Very good, thank you. Other business? Oh, we have a.
Funded
agency.
We're gonna try along. Funded agency, funding application policy, Dawn, apologies.
Yeah, no, that's okay. Very quickly. Before you is a policy, funded agency funding application program and evaluation. This policy is really just memorializing our funding process. It's been a work in process. It's been a joint project between Jenny and myself and Shannon. Putting this together, it has been reviewed by legal, it was reviewed by Frank, and now it's before the trustees for review and approval. Especially considering we are right at the start of our funding process, so we wanted to get this to the trustees sooner rather than later for approval, so we have an actual policy in place.
Great. Any questions?
Thank you.
I've got just a couple of observations. And great job. But this is just word, page 3. 180 days, this is under the documentation, the copy organization's most recent. Oh, now that I see that, okay, I was actually adding most recent fiscal year. My thinking is, if I'm an organization that does audits every other year, is that going to be okay with us?
Our organization's this is the external financial audits, those are done annually
By
their CPAs.
right, and they're obligated every year to do that.
Correct.
So, okay, because what I was thinking is 100 days of the organization's most recent fiscal year end. In other words, having a trigger based on that as to what audit you're going to be getting. Then I think you're good there. The verification of current this is on page 4 at the top, verification of current registration with the Department of State and Division. It's implicit that the registration you're looking for would be current, but I'm looking at it and saying, okay, verification of current registration just as opposed to registration. I know if it's not current, it's meaningless, but I just clarity. On page 5, under requirements, must demonstrate measurable contribution to expanding access to primary care and mental health services. We're not, the special act doesn't limit us to primary care in terms of expanding access. So I just think a general statement of, in other words, that access to healthcare in the community or something to that effect is probably more accurate for us. And just the one. Have no conflict of interest prohibited by applicable law. That's fine. Initially, when I first read that, I didn't. It struck me as if it being overread, prohibiting any conflict of interest, which would prohibit us from being involved in other organizations with applicable law, and cleans that up.
I move that we accept.
One comment, if I should. The other one in the requirements, do we not have anything about supportive? We've got increasing healthcare access for uninsured and implementing preventative health initiatives. Should it not be implementing preventative and supportive health initiatives? Because that is one part of our.
It was indeed, it was indeed.
Right.
How would you, we could come up with, I know we had, do we just want to say healthcare access and implementing preventive and supportive health initiatives? How do we want to word that section? So we don't have to come back.
I think that suffices.
Yeah.
Does that suffice? Okay.
Michael,
Page 3. First question. Who are we funding now that's not a 501c3?
Well, we have in the past, now no one,
right,
we have in the past.
That's what I thought.
We do have an LOI currently that's for profit.
And I'm not troubled by that, you've got the exceptions there. The next bullet, regarding, the third one down, copy of organization's current board of directors with qualifications.
Yeah.
I'm not gonna get in. I do not want this group having to determine whether or not they're picking qualified board members.
I agree.
That are diverse and can answer all of the needs. I think that's just that's an overreach.
Overkill.
You know, we want a list of the directors, we wanna make sure what county they live in. So that they're, some of these are multi-county, but not qualifications.
So just strike.
I would just strike
Strike
it.
it.
I would just strike it.
That's in our, I mean, that's on our easy impact, it's.
But we can change it, and we can update that, just is it in any other policies? That's the question, and if the answer is no, we strike it, we can update an easy impact, that's fine.
Yeah. The next bullet, organization's most recent financial audit, include the language in management letter, please.
Do they all have management letters
No,
though?
no,
Do not.
No, I mean, if there is one, it's usually because they're noticeable. A lot of them, and not everybody calls it a management letter anymore, I know that.
Yeah.
But if there is one issued, it should be forwarded. Number 2 on page 4, letter of intent. Pre-screening step to assess eligibility and alignment with district priorities. If the applicant has not previously applied for or received district funding or for a new program or previously unfunded program, we want them letting us know in the LOI process, isn't that correct?
Well, this is asking for a submit an agency pre-audit. So we have to do a pre-audit on them if they have not.
Right, if they have not previously applied, if we've never interacted with
Never.
them before and they've never funded them before, we do a pre-audit.
Which includes a site visit and requiring documentation.
Well, the letter here is letter of intent, LOI, and I think that.
Maybe it should expand to letter intent for those not.
Yes.
Not receiving.
There's
any
still a
funding
process
previously or-
for those that are bringing us a new program, is the point. This is unrelated to this document, but at the very end on page 6. It's the first time I've seen this. Members of the Board of Trustees are publicly noticed on the IRC HD website, and members from applicants are welcome to be part of these meetings via Zoom, preferred due to size of meeting space. It just I underline that, that's interesting. The reality is, we do have sometimes where for chairman's meetings, we know we're gonna be out of space. When those happen, or we're in advance as we go forward this year, let's just avoid the awkwardness of that and parking and figure out an alternative. That just made me
Alternative
think of
place,
that. I
rather
wanted
than have
to,
all this in here. I have to agree with you.
You
That
know.
makes sense. I mean, whatever.
I feel bad for those who, including us, who get here late and there's no place and you're parking in somebody's yard or across the street where you don't belong.
Right.
So that's it's unnecessary for the document, but I wanted to.
So
say
I
that.
was gonna make a motion to approve these as amended, but unfortunately, I think you're gonna have to come back with the.
With all the changes.
document and show us.
We can.
Sorry, Dylan.
Can it be changed for tomorrow's meeting? We'll probably make the update.
Sure.
And then send it.
They're that easy, sure.
Yeah, they're
Go
not,
for
we
it.
can vote on them tomorrow, I think. Yeah. Okay. Yeah. I know.
Okay, now I'm gonna go to other business. Get my order in order. Any other business? Any public comment? Yes.
One very quick thing, because I see Mr. Westcott needs to go. With regard to that discussion with the gentleman from VCOM about the chicken egg situation. Has anyone from the board, executive director, and he gone up to Tallahassee and talked to these people directly? Because if you're just using it as consultant or lobbyist, you can swing a stick at this time of year and hit anybody pipes with it. Having done lobbying up there to getting things done up there for the town with the Indian River Shores. If you're sitting there personally, can answer the question and show that the board has a commitment to what this for VCOM to move forward, I think that'd be very powerful to getting something done. So just a suggestion.
Thank you.
Thank you.
Thank you.
We stand adjourned.
Thank you, Gary.
Of course.